looks like ketones might suppress endogenous glucose production. Higher fat, and particularly saturated fat, cause greater hepatic insulin resistance. Your chance of getting remission at 1 year is 86%. Here's one thing you could tweak in the diet that can help control your glucose without it being related to weight loss.
What are the best dietary approaches to type 2 diabetes? Our guest today is Dr. Nicola, who has an extensive background of both clinical and research experience in diabetes and nutrition. She's a registered dietitian, and she also received a PhD from Imperial College London for research on diabetes prevention. She also trained at Johns Hopkins and at Tufts, where she was a Fulbright scholar. She's currently research program manager at Oxford University, where she studies diabetes remission interventions. We discuss the effect of different diets on type 2 diabetes and why information on this topic seems so confusing. People get a lot of mixed messages. They go on social media and every guru is promising that their diet is the one that cures diabetes, and conversely that every other diet is ridiculous and even criminal. Why would you put people on this diet or that diet? And the story sounds similar from all of these sources, and it is true that you can find some evidence. We can talk about levels of reliability and data quality, but it's true that you can find some arguments for all these different dietary patterns in terms of putting diabetes in remission and things along those lines. You must get these same questions from your patients all the time.
Sure.
So I wonder how you explain this confusion to them.
Yeah, I mean, generally, what we know definitively in terms of remission, so cure, I prefer to use remission because I think it describes what's happening most accurately. It's that right now you don't have diabetes according to diagnostic criteria, but it doesn't mean that it's not going to come back. So I think that's the right term to use. And the best evidence we have now is that weight loss, however you achieve it, probably is the primary determinant of remission. So there's that wonderful graph in the direct trial where if you lose 15 kilograms or more, your chance of getting remission at 1 year is 86%. And it goes down if it's just 10 kilograms or more and down further. So you can see there's kind of a dose response effect of weight loss on remission. And that's a pretty strong bit of evidence. Right now, that trial is the best one done so far. It was with a meal replacement product. Do I think it means that you need to use that diet to get to the weight loss? No, I don't. Everything that we know about physiology and short-term trials suggests calorie restriction and weight loss, however you achieve it, are going to help you get to your goal. So that's what I tell my patients. And there are a million ways to lose weight. There are two things that I think are interesting, independent of weight loss. And the first one is what my research is actively looking at, and that's dietary protein. And the basis for this is that what we think from the direct trial and accompanying physiological studies is what's getting people remission is they get back the first phase insulin response. And that is like, let's call it a spike, like the massive spike of insulin that basically happens after you have a glucose load or a meal. So it goes up, it brings down glucose straight away, and it helps you control your postprandial glucose concentrations in particular. And what the direct study showed is with weight loss, people who did get remission and didn't get remission both had improvements in insulin sensitivity. They both had improvements in liver fat. They both had improvements in pancreatic fat. But the distinguishing factor was the first phase insulin response. If you got back the first phase insulin response, you got remission. If you didn't get the first phase insulin response back, you didn't. So this pulse of insulin after a meal seems to be really key for controlling blood glucose. And so what's interesting to me is that protein, specifically the amino acids in protein, nudge the pancreas really powerfully to produce more insulin after a meal. So that's one thing that I think is intriguing. Even more intriguing is that the pancreas or the beta cells remain responsive to amino acids, even in late stage diabetes. So what we know with regard to beta cell functional failure in type 2 is they don't respond to glucose very well. So even if your glucose goes up after a meal, you have 2 slices of bread, whatever it might be, the sensor on your beta cells no longer detects the glucose as efficiently as before. So it can't send the signal through to produce more insulin. But guess what amino acids do? So the signaling pathways of amino acids on the beta cell seem to remain intact, even if you've had type 2 diabetes for 10 years. And so that's really exciting, because it probably means, I think, my hypothesis, that higher protein can lower your blood glucose independent of weight loss. There's a lot of evidence that it does. But secondly, it might be an effective approach for people who've had type 2 diabetes for a long time. So that's my basic description of where I think the evidence is. There is some earlier data of plant-based diets, super high fiber and high carbohydrate as well, on achieving normal glucose concentrations in type 2. I don't think that evidence is as strong for everybody else, but it's a way of losing weight, and many of my patients go that route.
So then does that mean that in addition to the general advice of whatever sustainable diet helps you lose weight, you also advise a substantial intake of protein together with that?
Yeah, I do. With most of my type 2 patients, absolutely, yes, I do. I mean, not only do I think it is physiologically a powerful tool for glucose homeostasis per se, there's moderate, maybe let's call it semi-poor quality evidence that it might help with weight management. And I say that just because the effect size is pretty small. Like on average, if you look at weight loss maintenance trials, it looks like higher protein diets do a bit better, but it's not a huge effect. So I don't really hinge my treatment on that, because I don't think it's very strong data. But, you know, if you have a patient with overweight or obesity and type 2 and NAFLD, because lots of patients with type 2 diabetes have high liver fat, protein helps you fix those three things. But one thing I would add, I mean, it works pretty well because I deal with a Western population. People are happy to have more protein, you know, it's quite acceptable. But I always consider the cardiovascular side of things. So I really try and promote half animal derived, half plant derived protein, because you get a good mix in there. If you're going for the plant derived proteins, it's fiber and all of the other goodness as well. But it's frankly easier to meet your protein targets with animal-derived products for most patients.
Yeah, molecularly, do we know how the glucose, presumably the insulin signaling pathway is blocked in the beta cells, but the protein response seems to be preserved? Do we have any idea how the selective preservation of the signaling works?
No, we don't. But I have a paper hopefully coming out soon. It's basically a review, and the whole purpose of it is, I think, and my co-authors believe, we have ignored the potential of amino acids for promoting an insulin secretory response. And actually, even more interesting as well, and scientifically intriguing in the sense that maybe this is where nutraceuticals could go, is that glucose there's only glucose. Glucose-stimulated insulin secretion is just one thing. It's the glucose and it's the coupling to produce a release of insulin. There's 20 amino acids. And we think they all work slightly differently. So I was going to say the stimulus secretion coupling of glucose is pretty well characterized, and it's easier because there's just glucose. With amino acids, there's 20 of them. There are shared and distinct pathways. So they're shared with glucose stimulated insulin secretion, but some pathways are distinct. The different amino acids probably work through slightly different pathways. And that probably also explains the potentiating effect, that because they work differently, they're adding, we think, a couple of amino acids together, maybe just 3 of them, you could get the maximal insulin secretory response compared to whole protein. And we think that's where that could be a really exciting path for nutrition research.
In terms of quantifying, if we were to compare the effect of weight loss to the effect of manipulating protein intake, what are we talking, whether it's a rate of remission or however we would quantify that to put the two in relative terms?
So I can't answer that question because we simply don't have the data, and the studies that have been done are not comparable. The thing about weight loss that is worth acknowledging is it does improve hepatic insulin sensitivity, improves muscle insulin sensitivity, and it seems to fix beta cells if you've had type 2 diabetes for short duration. You know, it improves a bunch of cardiovascular risk factors. So, and the level of certainty there is much, much stronger. What amino acid do I think the most exciting part of it is just almost like an added benefit, almost an adjunct. You know, so I don't think you would ever, in many cases, intentionally design a clinical program where you wanted to maintain someone's weight loss, hopefully you'd still get some weight loss. But for me, this adjunct of adding amino acids might mean that instead of having to lose at least 10 kilograms to get remission, maybe if you could just get to 5 to 7 kilograms, the added benefit of amino acids on that insulin response might help you get there. And I think if we could achieve that, we would increase the number of people at a population level who we could help get remission.
In terms of an increase of protein, that would be a swap with some of the carbohydrates, some of the fat, or does it not matter?
I think it probably has to. Some of my, hopefully, one ongoing study I'm doing is trying to tease this out a bit, what the ideal proportion should be. And I've got a few other studies planned. Based on the data available, I think you have to be about 30% kcals from protein and about 30 kcals from carbohydrate, probably as a maximum. And the rest fat. And again, let me reiterate, I always emphasize predominantly unsaturated and minimize saturated. It's worth mentioning we don't do dose response studies enough in nutrition. And the reason I say 30 is because that's what the studies that looked at this looked at, and the comparative group was 15 or 17. So maybe 25% of calories from protein and 30% calories from carb would do the same. We don't know if there's a cutoff. So the higher or the close as my patients can get to 30%, great. But if it's a bit of a struggle, I don't worry too much about it. It can be tough to get enough. So I give out diet sheets and I call things primary proteins and secondary proteins. And I emphasize that they should try to get both in every meal, particularly lunch and dinner. Breakfast is the hardest. So for breakfast, I might even encourage a protein powder shot, or having protein powder in a cereal, whatever that might be. But for lunch and dinner, what I would be looking at, the primary protein would be something where the vast majority of the calories in it are just protein. So you're talking chicken breast, tofu, mycoprotein, that's like a corn vegetarian alternative, where there's not much fat in it, there's not much carb in it, it's just protein. I call that a primary protein, and that's the easiest way of getting enough. And then in addition, I have secondary proteins. So those might be things like pulses, where yes, they've got a decent amount of carb in, but they've also got enough protein that if you combine the two, you can get closer to your 30% of calorie mark.
We've talked about what the best diet would be, and it's not really a name diet as people like to throw around on social media, but technically any of these name diets would work. Low carb, low fat, low calorie, intermittent fasting, all of these approaches could work. And I think we see evidence that all of them do work, at least for a subset of people. And by the way, I've always wondered if the fact that we only see them, all of these pretty much work for a percentage of people, if that means that it's the percentage of people that are attuned to that intervention, or is it the percentage of people that would do well on any intervention because they are the most disciplined ones or the ones that stick with whatever you give them? Do you have an opinion on that?
I mean, I think based on the type of studies that have been done, and they are typically free living, very rarely do studies provide food. So the onus is on the participant in the study to stick with the dietary intervention and so forth. So for me, the evidence is on the side, based on the type of trials that have been done, that it's people that would probably do well on most diets. But nonetheless, I mean, one of the things that I always find is striking is the amount of extra support that you can have in any weight loss trial. And so, I mean, I've worked on lots of weight loss research, and even when you're putting out an advert, so let's say, I mean, I did my PhD, I did my postdoc at Imperial College. It was well known for doing really exciting work in appetite hormones. So they develop, they do first in man studies of hormones that reduce appetite. So it had a good reputation for research. And whenever you put out an advert, say in a newspaper to recruit participants, people are so desperate for something that works. And they see that it's, whether it's Imperial College, whether it's Cornell, whether it's, a big name, they think you finally got the answer. So the first thing is the response that you get are people who are absolutely desperate for weight loss. They are so determined to make this work. And then you consider that they come into an environment where they get way more input than anyone would ever probably be able to give them in primary care.
Yeah.
And you have what should be a state-of-the-art diet to the extent that exists. And yet dropouts are about 30 to 50% from trials, even with that. And, you know, we see the weight loss is generally pretty modest until direct. I mean, 10 kilograms at 1 year was incredible. And by the way, I don't want to be biased, like Verta, you know, it wasn't a randomized trial, but it was a single arm open label trial. They got 10 kilograms in 1 year, so you can do it, but that's rare. Most weight loss trials, you know, it might be 5-7 kilograms at 1 year, and from then on it's straight up again. So I guess what I'm saying is weight loss is really, really hard. And yes, to your point, I think the people that do well in these trials are people that would do well on probably any dietary intervention, at least over the short term.
So in terms of the clinical approach, when you get a new patient coming in, do you explain that the end goal is going to be to lose X amount of weight? Do you give them a repertoire of possible dietary approaches, or do you have a default that you suggest? How does it work?
Yeah, I mean, a really great question. It's a lot of listening. And very often the first thing is you have to understand how much a patient knows. Your average patient knows more than me. So you don't want to be, as the clinician, like telling a patient, oh, by the way, this has this many calories, because your patient's going to be super knowledgeable. So the first thing to do is gauge how much they know. The second thing is I try to understand their goals. And this is important because remission might be, you know, the gold standard as far as the NHS is concerned. And why do we want that? Because it saves money, gets people off medications, lowers medical costs and so forth. But that might be not what a patient wants. So you have to, you know, what are their goals? What do they want to achieve? And then you also want to try and understand what are they willing to do to give up? Because many interventions are tough. And so you want to gauge all of this. But in general, yes, what I would do is I would explain, if remission is what they're after, I would explain the research in as lay fashion as I can. And I would say, here's what we know. What do you think about that? You know, let the patient lead that consultation, and then we would try to tweak things. I do always try to educate on protein, because I just think I'm a pragmatist, and as much as weight loss definitely helps, and 10 kilograms does, and so does 15 kilograms, people do struggle to lose that amount of weight, and then they very often fight against regaining it. So as a pragmatic approach, kind of saying, well, here's one thing you could tweak in the diet that can help control your glucose without it being related to weight loss. And that can be empowering for them to see their glucose go down and their A1C go down.
So you try to gauge which foods are very important to them and which foods they kind of could take it or leave it. And then you focus maybe on those to phase out.
Yeah, exactly. And I would be and I'm always really honest. I mean, sometimes I might just have like meal plans or pictures of foods and talk about what the approaches involve. Because, for example, like the meal replacement approach, you're talking 2 to 4 months of meal replacements. And people differ immensely, and they tend to be quite black and white about this, whether they're going to do that or not. The people that are just, I mean, some people just go, hell no. No, I'm not eating milkshakes for 3 months. Are you crazy? And it's a non-starter. So you might say, well, what about doing 2 meal replacements in a meal? But you would work with them in that way. If someone says, oh, I love carbs, I'm really into bread, really into potatoes, or culturally it's really important to me, it's how my family eats, there are certain things that just aren't going to work because you're running uphill, as it were.
Yeah. That makes total sense. Going back to this idea of the susceptibility to different dietary patterns, do you ever get patients who don't do well on maybe the first thing they try? Maybe they try a low-fat diet first, and it just doesn't work for them, and then they try a low-carb diet, and it works really well, or the other way around?
I mean, in general, I mean, patients are often fighting with their weight as a lifelong battle. And I can't remember the last time I met a patient that hadn't at least tried those two. So very rarely is it, trying something as straightforward as low fat or low carb. I like the tweaking approach and kind of food exchanges. So whether it's replacing some saturated fat with polyunsaturated, that usually with cardiovascular risk, that can be useful for patients. Whether it's replacing carbohydrate with protein, that's a switch that's not related to cutting calories. Whether it's increasing the amount of dietary fiber they have, these are things that fit into any dietary pattern. So even if they've tried something and it hasn't worked, or maybe, they might have done keto and it helped them lose weight, but their cholesterol went up and their doctor said, forget about it. Like, trying to work within a dietary pattern that a patient likes and then using those tweaks generally works better than, well, low fat over here and you go to low carb. So that's generally how I try to work it.
Yeah, so not being bound by the labels, but rather flexibilizing these things to whatever works for the individual.
For sure, yeah.
In terms of people on different stages of the progression, let's say someone who is healthy and wants to prevent prediabetes or diabetes versus someone who might have prediabetes versus somebody who has established diabetes. Is there a fundamental difference in terms of the dietary approaches, or is it all?
Ooh, I mean, that is such a great question. I mean, so certainly with type 2 diabetes, because you have this beta cell functional failure, and that's the primary reason that glucose is all over the place. And we are now have a growing amount of evidence in that population. So to me, they're quite different. If you go back to say someone with normal glycemia, do I think they'd have benefit from doubling the proportion of calories from protein? No, I don't. And the reason being is their beta cells work just fine. They produce enough insulin. And so there is some evidence, I'm not totally convinced by it, suggesting that high protein causes peripheral insulin resistance. If it does happen, the effect size is probably small. So I kind of weigh it up like this. Like if I think about someone with type 2 diabetes, the benefit of a high protein approach is that you're going to fix the beta cell, which is the huge problem, and probably simultaneously not have much of an effect on insulin sensitivity. But if it does, it's like, say you worsen insulin sensitivity by this much, but you're improving beta cell function by this much. Sorry, see if you can capture that. You know, your net result is a win for glucose homeostasis. Conversely, if you take someone who's got normal glucose tolerance, you're not going to get any improvement in beta cell function that means anything, because like I said, the beta cells work fine. But even if you do in a healthy person increase insulin resistance this much, well, the net result is you're possibly worsening their prognosis. And it's just almost not necessary unless you are exercising a lot over the age of 60, 65. I don't see any reason for having any more protein.
Okay, so the protein would be kind of a more aggressive step that you would only go to if the person already has established diabetes.
Yes. And then to the middle point, I mean, my answer is going to be non-committal. The reason being, we have such a poor amount of data in that population. All we know, I mean, the diabetes prevention trials have shown us weight loss of 5 to 7%, however you pretty much achieve it, seems to prevent the development of type 2. There have been some smaller studies trying to isolate, well, is it the fiber? Is it the saturated or polyunsaturated fat? None of it's convincing. It just seems to be weight loss. I'm interested in the idea of protein helping to keep glucose under control, because what we do know is you do have some deficit of beta cell function in prediabetes, but some of the things that we don't know is what the long-term effect of high protein might be on beta cells that work okay. And I think we should be cautious as scientists and not jump ahead and say, well, it works fine in type 2, so let's try it in prediabetes.
Right. Yeah. So the focus would still be on the body weight and the amount of body fat that the person carries. And for prevention, it would be try not to put it on. And for prediabetes, diabetes, it would be try to lose some.
Yes, exactly. And I think the intensity of the intervention differs or increases as you go along the pathway to type 2. So actually, prevention of weight gain is relatively easy compared to weight loss. Prevention of prediabetes is easier than prevention of type 2 once you've got prediabetes. So the interventions can be far less intensive, and probably for most people, general healthy eating. I know that sounds so vague and unspecific, but that's basically the truth. Exercising, not gaining weight, eating a reasonably healthy diet within a wide boundary of choices is fine for most of the population to prevent the development of prediabetes.
Yeah. If we were to insert another category in the middle, which is people who might have insulin resistance, but still more normal glycemic, right? So the pancreas is still able to compensate and maintain normal glycemia. There would it still be an issue of essentially a little bit excess body fat, but not enough to be pre-diabetic?
For me, when I think about insulin resistance, to me, that is just synonymous with overweight. I mean, I think that the population of, or the proportion of the population who have overweight and obesity is pretty similar to the proportion who have insulin resistance. And it's worth mentioning there's no actual, that I know of, consensus definition of insulin resistance. It might be a fasting insulin above a certain range, or the insulin glucose ratio, for example. But in general, those two things track so closely. There hasn't been a whole bunch of decent research on nutrition independent of weight loss on insulin resistance, and part of the reason is, like I said, there's no definition. You know, you could measure fasting insulin, and I think that's perfectly good. From all of the studies I've seen, weight loss has such a huge effect on fasting insulin that nothing else matters that much. So again, it's a question of lose weight however you can.
We also talked about effects of specific diets aside from weight loss, like, for example, low carb diets or low fat, high carb diets, which viewers often ask about. Now, there's less evidence on that aside from weight loss, but there are some studies, so we discussed possible effects of those dietary patterns.
There is some evidence in healthy people that going on a keto style diet, and to my knowledge, most of these have been like high poly, like low saturated fat, kind of healthy keto diets, do lower insulin independent of weight loss. So that's something that's interesting, because it seems to do so both in the fasting and the postprandial states. But I don't know if there's long-term data, not that I necessarily think it would stop happening over time. I don't think that lowering carbohydrate in the diet, independent of weight loss, unless you get to ketogenic amounts, lowers glucose independent of weight. So I think where we have these trials where it looks like low carb does really well and lowers glucose independent of weight, I think it's the protein. Where I think low carb lowers glucose under normal protein intakes is where it's ketogenic, because it looks like ketones might suppress endogenous glucose production. So I should just say that. So when I'm talking about low carb diets with you, I basically mean a high protein, low carb diet. And I think, by the way, I think that's what most low carb people are doing. We just call it low carb. And people forget that it's actually high protein. And I think it's the high protein that's the active ingredient.
For the crowd that loses weight and who puts their diabetes in remission by eating a boatload of like low fat, high carb diets, a lot of times they eat a lot of fruit, a lot of starch, but they cut out the fat. Is that just because it's an elimination diet, so they're losing weight, and that's the mechanism for the remission of diabetes in those cases?
I mean, I don't know for sure, but whenever you see the large amount of weight loss, and we know of the dose-dependent impact of weight on remission, it's really hard to attribute that normalization or lowering of glucose to anything else with any degree of certainty. And the same is true for any plant-based approach where you see this marked weight loss, because it's like, how do I distinguish these two factors? You can't. It's just speculation. I mean, I wouldn't be surprised at all if all of those beneficial compounds in a plant-based diet are improving some insulin signaling mechanisms in the muscle, do something good to the beta cells. I mean, that wouldn't surprise me. I would think the impact of that is small. What we know from, for example, clamp studies is if you feed more carbohydrate, you have greater uptake of glucose into the periphery. And so I would have thought if you switch someone to a high carb diet, you improve their peripheral insulin sensitivity. So that could be another mechanism. But before someone has in the overweight or obese phenotype of type 2 diabetes, a weight neutral study, high carb, high plant, I can't speculate further that it does anything much beyond or added to weight loss. You can measure what degree of insulin you need to shut down hepatic glucose production. And so if the amount of insulin you need to do that goes up, we call that insulin resistance, specifically of the liver. And from memory, some of the studies that look at higher fat and particularly saturated fat cause greater hepatic insulin resistance. So effectively, you need more insulin to shut down glucose production from the liver. And in that sense, what we might be looking at with those studies is it isn't necessarily a positive effect of excess carbohydrate on insulin sensitivity. It's the negative effect of a higher fat diet on hepatic glucose production. For prevention of type 2 diabetes and cardiometabolic disease, maintaining a healthy weight and doing a good amount of physical activity are so above and beyond in terms of effect size of your risk of type 2 diabetes and everything else. Nothing else really matters. I mean, does dietary fiber probably help a bit? Probably. Does having more polyunsaturated or mono than saturated fat probably help a bit with insulin sensitivity? Yes, but the effect of not gaining weight and keeping pretty active, they just slaughter everything else in terms of risk of type 2 diabetes.
Okay, quick summary of all that. The strongest evidence points to weight loss, however you get there. So that explains why we hear all these different anecdotes for completely different diets. There's no contradiction. One guy lost weight on a low carb diet, another on a low fat diet, another by fasting, and another by counting calories. They all got to the same destination using slightly different roads. In addition to that, there might be specific effects for some nutrients independent from calories and weight loss. For example, protein and amino acids stimulate insulin production by the pancreas. Ketones may inhibit glucose production by the liver. Unsaturated fat seems to be a little better than saturated fat for liver insulin resistance. And carbohydrate may improve insulin sensitivity peripherally in the muscle. Several viewers have asked previously about these classical studies looking at very high carb diets, improving glucose tolerance, even in the absence of weight loss. And it's not completely understood, but this might help explain those findings. But again, the effect of these specific nutrients is relatively small compared to weight loss. So the role of protein is an adjunct, as Dr. Guess called it. Knowing about this may help some people reach their goals. Others may not need to increase their protein and go on these very high protein diets if they can lose weight and get to where they want with other dietary patterns. And we looked at several examples of specific dietary patterns. We looked at a high protein one with 25 to 30% of calories coming from protein and another 25 to 30 coming from carbohydrate. And Dr. Guess uses that routinely. We also touched on ketogenic diets and high carbohydrate diets. So usually low fat, high carb, which some people do well on. All three of those dietary patterns can be designed to check all the main boxes. Low in ultra-processed foods, decent amount of fiber, and mainly unsaturated fats. Most of the time, diets can be tailored to support all aspects of health at the same time. These examples are not exhaustive, and they're just tools in your tool belt. They're not shackles. So don't let your hands get tied by these labels. If something's not working for you, change it. Just tweak it to fit your goals. So we heard from Dr. Roy Taylor a while back, also on type 2 diabetes remission, and now we heard from Dr. Guess. And you see that there are some patterns that emerge, right? So this is why it's really cool when we get the opportunity to talk to different people, all with a very high level of expertise in a field. And we also see some other details pop up around the edges, like these roles of the specific nutrients. So we're working towards a unifying model of type 2 diabetes. Really cool, right? And for people working on prevention, so completely healthy right now and want to stay that way, maintaining healthy body weight is number one, as far as prevention of type 2 diabetes. And again, that can be done with a variety of dietary approaches. I know you guys have questions about diabetes in thin people, type 1 diabetes, continuous glucose monitors, CGMs, especially in healthy people, and a lot of other questions. And we have videos on all of that in the pipeline. So stay tuned. Thanks for watching. I'll catch you next week. Bye.